Hello everyone, I'd like to introduce our speaker tonight. My name is Father Mike McLean. I'm the pastor here at St. Gregory's. And on behalf of our parish and our adult faith formation team, led by Betsy Solon and Stephanie Loria, I welcome you to tonight's Respect Life Month lecture entitled Healthcare That Kills by New Jersey licensed podiatric physician and wound specialist and parishioner, Dr. Vincent Delle.
Thank you.
Adult faith formation in our parish provides opportunities for lifelong learning that allow us to better know and love Jesus Christ, to live our Catholic faith, to specifically think tonight in the area of the fifth commandment, do not kill, and all of our Respect Life principles and teachings, so we can both be better informed about what's happening in our culture with these issues and also be a greater witness to the faith in the world. In addition to his medical practice, Dr. Vince is also a former hospital bioethics committee member. He's lectured on various ethical issues emerging from advances in biology and medicine. And he's also a lay Dominican. A few of the lay Dominicans here today. When we normally think of doctors, we think of men and women doing all they can to save the lives of their patients and to promote their health and well-being to the greatest degree possible. Dr. Delle will show us tonight, however, how some segments of the medical community, under pressure from radical ideological forces, have not followed these principles but have disguised contraception, cloning, abortion, euthanasia, and other practices as medical treatments and as necessary medical treatments, but in the end leading sadly to untimely death and contributing to a culture of death. We'll have time for question and answer after the talk. And please fill out the surveys before you leave, if you could. So please now join me in warmly welcoming Dr. Delle.
Thank you, folks. Thank you very much. It's such a pleasure to be here on a night like this. I always like to think in coming to these events, we're doing God's work in itself. Trying to learn and understand a lot of what's going on in the world today, and trying to bring it to an understanding for not just ourselves, but for people that we are surrounded by. Yes? Sure. We don't have any hookup, do we?
In the car.
Okay. I'll speak up. I'm sorry. I'll speak up, Father. I just want to say thank you for this invitation as well. I do believe that we can get a lot accomplished tonight. At least my goal for us is to gain a greater understanding of just exactly what's going on in the world of medicine and research in particular, and how some things just aren't fitting quite right into the whole scheme of things. Certainly, in considering our faith, we really have to make some better decisions. We have to gain a greater understanding of what's out there and what's happening. I think tonight we'll be able to at least build a greater foundation and be able to take that to not only our families but to people we meet in everyday life, and be able to introduce them to what's going on in the world of medicine and science and research in particular. So, if I may, there is one thing that I really have to make sure that you truly understand here, and I'm going to spend a little extra time with it, and we're going to actually have a little bit of a film loop for about 2.5, 3 minutes that will really, I think, set the pace for what's going on later throughout the discussion. And that would be the concept of fertilization and conception. I want you to realize that both words are interchangeable. They both mean the same thing. Why that's important for us to know is that most of the threat that goes on today in the world of research science has to do with the fertilized embryo, the living creature, the living human being. And this attack on the fertilized embryo, on the living being, is something that we seem to be almost ignoring from the standpoint of information that it's at least given out. We hear about all wonderful things that are going on in the sense that one day we'll be able to repair human body parts and things of that nature. But how are we getting to this point? Are we permitted to create evil in order to create good from it? The evil of, you'll see soon, abortion-like procedures to steal tissue and to steal different cells that will definitely then be implanted into organs or into unhealthy organs, unhealthy tissue, and hope to see that change and become better. We have some very serious questions to ask about the procedures and methods that are about to be used. So let's have a quick definition on fertilization. This is pretty concrete. This is truly foundational. The belief in fertilizing and fertilization and contraception, it's the process by which the egg and the sperm interact, achieve mutual recognition, and fuse to create a living human embryo. Let's not escape that. The living human embryo part is essential that we truly understand. So the living human embryo, which then develops to form a new individual, thus allowing for the continuity of a species. This is textbook. This is definitely found in all our science books, all our medical books. It's been established by the embryologists, which are the specialists in this particular field, and they make it very clear that life begins upon conception and fertilization. Again, those two words are synonymous. You'll probably hear me use the word fertilization more frequently. I'm just accustomed to that. So that's pretty much what we're going to discuss and point out examples as to where this is not working the way we had hoped for. This is our video. It's about 2.5 minutes long, and I'll just point out that this is going to actually be where the sperm and egg are basically going to meet and unite and fuse, and at that very moment we have life, human life. A little bit after that, we'll notice that the egg will start to move and find its place in the woman's womb, in the uterus. And this is when, almost immediately after fertilization, within minutes, this starts to take place. But the process is of movement now, not of fertilization, but of movement to the uterus, is about 7 days in many cases. And it will find itself nestled then into the uterus, and then the egg will implant, basically bury itself there. And that's when all the hookup for nutrition, protection, everything necessary for the human egg to develop even further, or human embryo to develop even further until finally birth takes place. So Ed, if you would run this, please. Of course, the little white-tailed cells are male sperm, and there's our first glimpse of the female egg. Fertilization. Within a minute or two, cell division will start. This is inside the egg now. conception. Now we're looking at the egg from the exterior. You can see it's starting to move. And it will be a several-day process before it reaches the uterus and implantation takes place. At this time, the cells are multiplying. Implantation is beginning. And is complete. Thank you. Thank you. Pretty fascinating, huh? Yeah. That's a YouTube video, by the way, so you can easily Google that if you care to look at it. It's actually about 15 minutes long. It takes it through all the steps and stages. Very, I thought it was incredibly clear how all this works, okay? The thing, though, is that we as everyday folk don't really recognize that that is a human embryo. Father Thad Pekulchik, maybe many of you people may know him from EWTN. He is frequently on the program there. He's a doctorate in neuroscience. He's also the education director for the National Catholic Bioethics Center, which is located down in Philadelphia. And actually last month I had the pleasure of sitting through a couple of his lectures at their Philadelphia conference that they have every year. And he said a lot of interesting things that day, but I love this line. Embryos, of course, are strikingly unfamiliar to us. They lack hands and feet and voices. Even their brains have not yet developed. They look nothing like what we expect when we imagine a human being. But they are as human as you and I. They're simply younger, smaller, and more vulnerable. So my goal for you folks tonight is truly understand that that little clump of cell material is not anything more than what we are, albeit it's the most immature state that it could possibly be in. But these are truly human beings, and we'll see what happens to them as time goes on here. All right. The first thing I want to talk about is contraception. We just looked at conception. Contraception. And all the pills and all the capsules and all the tablets that are out there, we certainly know when we say the pill exactly what we're talking about. And that is birth control pills here. I just love that slide there. It certainly makes that point. Next, please. So we'll have a little brief history of the pill. In 1950, Margaret Sanger, the founder of Planned Parenthood, she underwrote the research necessary to create the first birth control pill. She raised about $150,000. There were other folks who contributed significant amount of money there. There were researchers, clinicians. Most of the people that they tested the pill on were in Puerto Rico because the laws there did not take in the Puerto Rican Commonwealth when it came to the Comstock laws. They're so old, but it has to do with transportation of any kind of sexually related materials through the mail, and they utilize that law for a multitude of different things. But all the testing was done in Puerto Rico, so that's something that we don't really hear much about. And the first drug approved in 1957, Inovid, This was treated and at least accepted by the FDA as a new medication for the treatment of menstrual disorders and infertility, not contraception. Interesting in that that pill was originally designed and from its first day was called a contraceptive pill, but kind of backdoored it in with the FDA. They needed to find a way to get it approved, and this is where they used it as a for menstrual disorders and infertility. Interestingly enough, within about a year or two, women were pounding on their doctor's doors asking for this pill, finding out that it had to do with contraception, that it would prevent pregnancy. Before it reached its approval in 1960, there had to be at least 500,000 women who were using this in what's called off-label medications. That's not an unusual thing. I've had plenty of experience with that just in my own practice. I treat a lot of diabetic neuropathy, for instance, which is a numbness, burning, and tingling, especially found in the feet, but fingers, hands are involved too. And there are certain drugs that have been used on the outside for people who have had a multitude of problems, including diabetes with neuropathy, those who had epilepsy as well, or any kind of seizure activity. The drug Neurontin was often prescribed. Neurontin, over time, they discovered, also helped with diabetic neuropathy. So before you know it, we're prescribing, and it's been going on for a good 40 years, Neurontin for diabetics, and this is approved by the FDA as a anti-seizure medication. So we really try to, I don't want to say mix, but we certainly try to look for something in even other medications to hopefully bring some relief to our patients. So off-label, it was used for about a year and a half, 5 million women, or 500,000 women. Now, what exactly is the pill? The pill can either be one or two, most often, synthetically derived hormones formulated to prevent pregnancy. The next question we're going to ask are, what are hormones? Hormones are unique chemical messengers. They control major bodily functions. Heart rate, sleep cycle, sexual function. Sleep cycle, many people know melatonin here, right? Must have used it one time or another. That's a hormone, over the counter. Many of the products are over the counter, used to help regulate sleep, right? So that's what hormones do. An interesting concept, though, is coming up here with the use of these contraceptives. We're using hormones here, well, in most cases now it's prescription, but healthy women, those without any kind of medical problems, are now being prescribed medications by their physician for extended periods of time, just so to prevent pregnancy. So what have we done here? We've moved the concept of pregnancy and childbirth from a very natural, normal state into a disease or pathological state. It doesn't mix, right? It doesn't seem to mesh. And here we're giving healthy women a prescription medication, but they're not sick. If you're sick, you go to your doctor. He'll write you a prescription, hopefully a couple of days, you're feeling better, and everything's fine. But, we're just kind of doing things a little bit backwards here now. Okay, the first thing I'm going to talk about as far as these oral contraceptives that are not the friendliest are the abortifacients. These are drugs that basically cause abortions to occur. The morning after pill is the very first that I'll discuss here. It must be taken within 72 hours or 3 days after intercourse. And they include Plan B, One Step, Next Choice, Ella, which is in that list the only prescription medication. The other two are over the counter. And sadly, I have a friend in the parish who's a college professor who just told me the other day that many of these non-prescription morning after pills are sitting in vending machines at the university. Vending machines. Right next to your, candy and cookies. It's a horrible thought. So, excuse me. These abortifacients, these two medications, morning after pill, and the other one is the RU-486. That came up a little smaller on the print. The RU-486 is just recently, well, since 2000, been approved in this country. But I'm going to go back to the morning after pill, since it's so commonly used. It works by mechanisms of action. All drugs have that, a mechanism of action. How does it work? What does it do to the body, to the cells in the body? The first mechanism of action with the morning after pill, it'll temporarily stop the release of the egg from the ovary. So you have a healthy ovary there, but the medication will prevent the release of the egg. So you could have the sperm there, but without the egg, we're not going to accomplish anything. The other thing is that it prevents fertilization. So you may have healthy sperm, a healthy egg, but the drug will prevent them from coming together. So you're not going to be able to have fertilization. The other mechanism of action, and that's the one that's most fearful here, prevents a fertilized embryo from attaching to the uterus. If fertilization should take place, we have a human being now. It's lodged into the uterus, or certainly on its way, but once it gets there, the attachment is weakened. The drug has an effect on the membrane of the uterus, and it will not hold. And in fact, it's very common to see hemorrhages here, where the woman will suffer with a whole bunch of issues, from tremendous nausea and pain, but the hemorrhaging can be very can seriously affect their lives. But on top of that, what do? We just move the cell right out of the body. The woman doesn't have the egg any longer, or the embryo, excuse me. Now, RU-486 is the other abortifacient. This came from France, and this is used in the same manner, strictly as a way to exit the fertilized embryo. It used to be for 49 days after a woman's last menstrual period. It's now been revised in about a year or two ago to 70 days, where if it's within the first 70 days, you take this particular pill, and it's usually under a doctor's care. It's usually a couple of visits involved. The lining, again, of the uterus will be so weakened that the embryo is displaced. And ultimately, that's an abortion. Okay. So those are the two primary concerns with the pill, the abortifacients. All right.
Can I ask a question? Sorry.
Sure.
There's a question. So individuals that take these drugs,
Mm-hmm.
it works immediately, but if they were trying to get
Doesn't always work immediately.
well, but they were trying to get pregnant at some subsequent time.
Mm-hmm.
Does it have any long-term effects to affect a future pregnancy?
It certainly can. It certainly can. Now, everybody responds differently, but a lot of the literature I've read, there can be some prolonged issues. Yeah, it certainly can strike back. Of course, my concern has to do a lot more with the child here, but I wanted to include what happens with the mother. Many times there's a 50% increase in breast and cervical cancer. There's an elevated risk of DVTs, or deep venous thrombosis, which are blood clots found in the legs. I do see a lot of that just in my private practice. They will dislodge. They will become what's called embolisms at that point, which is just a moving, traveling blood clot, which is incredibly serious at that point. They can travel to the heart, brain, and lungs. To the heart may lead to heart attack, to the brain certainly stroke, and to the lung, pulmonary embolisms. They're definitely life enders. They are medical emergencies, and if not treated, likely death will occur. So we have to be very concerned over that from the mother's standpoint. Heart attack and stroke is especially elevated in smokers. Speak to any family doctor or gynecologist, obstetrician, they really have to know their patient. They have to recognize their lifestyle habits, certainly before they prescribe these things. And then, of course, there's liver and gallbladder disorders. Go to the next one, Ed, please. There's a couple of other things I wanted to mention. Some pills are just one single hormone, progestin-only type pills. They have up to a 600% increase in ectopic pregnancies. This is where the embryo gets lodged in the tube heading towards the uterus. Lodges there, it adheres, and it starts to grow. And what it can do is rupture the tube, the wall of the tube. And this is a serious, serious condition. It's very life-threatening. There has to be removal, or else death is almost imminent there. I did include Yaz and Yasmin. These are two third and fourth generation pills, meaning that they are frequently used nowadays. I have seen them on a number of my history and physicals from my own patients in that age bracket. And this has some serious side effects. Now, this is just a normal birth control pill. This is not an abortifacient like I had mentioned of the other two. This is made by Bayer Pharmaceuticals. It's already attributed to 200 deaths and over 8,000 lawsuits settled for $1.7 billion. Pretty significant. And the company still manufactures it at a massively quick and healthy rate. So that's what we're faced with there. This I wanted to throw in because when I read this article a few years ago, it just blew my mind. The pill, these hormones, are affecting our environment. Scientists have linked reproductive abnormalities in intersex fish. What on earth are intersex fish? Well, they are fish with both male and female sex characteristics to the presence of hormones in rivers and streams from sewage and water filtration plants. So the water, after being filtered, will work its way back into the system, the ecosystem. Fish will be swimming in these regions. They will be exposed to these hormones, and they will start to develop characteristics of both sexes. Another article that I did read on a follow-up of this, somewhere I want to say in either Switzerland or somewhere at least in that region, I think it was Switzerland, goats were grazing in a particular area that had a lot of water feeding these ranges, these grassy knolls. And the goats that were eating the grass, I assume, right? That was nourished by the water from these particular type of filtration plants, they were demonstrating changes in their sexual appearance. So, you know, it's hitting home. I mean, many of these fish too, we could be eating, and we are going to ingest these same hormones. So, pretty interesting thoughts, huh? All right, so I wanted to touch on human cloning as well. This is always an interesting topic here. Human cloning is the creation of genetically identical copy or a clone of another human. It's done in two forms. Reproductive cloning, meaning that we clone human being, the cloned human being is implanted back into a woman's uterus with the aim of bringing it to birth. Now, mention here, I'm talking about humans now, right? We're not talking about Dolly the sheep or anything else like. We're talking about humans. That is called reproductive cloning. This too is all done in the laboratory on petri dishes, in little test tubes, things of that nature. And it's done through a lab technician, through a research physician or research scientist. The other form of cloning is therapeutic. This is the one I want to spend a little time on because you're doing some tough things here. Therapeutic is basically doing the same thing, but instead of allowing or replanting the embryo, now even though it's cloned, it's still a living embryo, right? Instead of implanting them into the uterus, they're destroying it and they're stealing the cells, the embryonic stem cells, and the goal is that they hopefully can utilize these cells to replant back into the cloned person. There's no rejection. They can place it into a diseased liver or a diseased kidney, things like that. These cells have the possibility of basically turning themselves into whatever it needs to be to create a remedy for the disease or pathology. Right? So, this is how cloning takes place. This is a pretty fun diagram. That top gray circle with the red dot in it, let's say that's me, and I want to clone myself, right? That red dot represents the nucleus, which is the brain trust of every cell has. Below that, the yellow cell with the green nucleus in the center, that's just a random egg, an egg that's been donated by any woman for that matter. Now, what has been done here is that in both cases, the nucleus has been removed. The round dot, the red dot rather, and the green dot, both have been removed. In the case of the egg, the yellow circle that's blank, that particular circle is basically considered now like a blank sheet of paper. What goes on here is that the cloned individual, the nucleus, that red nucleus, will be fitted into the blank yellow egg cell. So what happens here? If that gray cell was me, that's a somatic body cell, which means it has all my 46 chromosomes in it. And we have this donation of an egg, a blank egg. All my cells are now into this blank egg. They can take that, it's now fertilized. They can take that to true fruition, and the next thing you know, a duplicate of me is being born 9 months later. Of course, the age difference is significant, but they're not doing that yet, thank God. But what's going on is below, under therapeutic cloning, they're destroying the the embryo, and they're utilizing these cells again. And they're doing all significant type of research on it. And these cells, once again, have the potential to turn things around for people who have a very diseased state. Again, if there's Parkinson's disease, for instance, there's talk that they want to inject these cells into the brain stem of a Parkinsonian patient with the goal of transforming these cells into healthier individuals. Move on. And that's Dolly. She was the very first large-scale clone. She lived for about six and a half years, which is a much shortened lifespan. They usually live for about 20. And there's got to be about 4 or 5 dollies now. I understand that she's in a museum in Scotland where the cloning had originally taken place, was Scotland. She's in one of the major cities there in a museum for her efforts. But that's one of our first steps in this field of cloning. Okay, now we talked about stem cells. This is the other thing. This is why they want to do cloning, part of it. Stem cells have a remarkable potential to develop into many different cell types in the body during early life and growth. So these stem cells are something that these researchers want to go after. They feel that they can do a lot of things with this. They can turn some things around. And what do they get out of it? they win Nobel Prizes on stuff like this. It's a huge financial thing, and needless to say, their egos probably as blown up as the size of this building by that time, right? So stem cells behave in two ways. You have self-renewing, unspecified cells, and what they do is basically maintenance and repair. Take skin, for instance. We have a new set of skin every 90 days, every 3 months, 90 days. Of course, at various intervals. But these type of cells will constantly turn over and create fresh new skin, so that we have this constant turnaround of skin. But under special conditions, they may become tissue and organ specific with special functions. So they can be liver, I said kidney, blood, neurological for the nerve cells. They can actually be placed into these regions where there's disease and hopefully turn things around. Next one, please. And that's the embryonic stem cell. Now, interestingly enough, there's two out there, two types, well, there's more, but these are the two we'll concentrate on. Embryonic stem cells are those living embryos that are destroyed for their cells, and they're lethally extracted. So you've just aborted an embryo. You killed an embryo to do this, which is going on pretty routinely on the research field. The other one that we talk about very frequently are adult somatic stem cells, and these don't require any destruction of the embryo. These are the good guys, you might say. This particular type of cell is very functional and has been known to help a lot of people. Next one, please. As far as adult stem cells, there's the embryo survives. It's been documented clinically. They have benefited things like lupus, MS, leukemia, coronary heart disease, ovarian cancer, brain tumor, Parkinson's disease, and spinal cord injuries. Embryonic stem cells, the embryo is destroyed, and to this day, they have done absolutely nothing to improve general health. So you got to ask yourself, why on earth are these researchers still doing it? Once again, I go back to, it has a great potential in theory, but they want to win Nobel Prizes. They want to, get the big name, make their names powerful. And I guess they think they're doing the right thing too, they really do. Now, look at that happy face, huh? This is Dr. Mitalipov. He's a geneticist. He's from Russia, actually Kazakhstan, I believe. He runs the Center for Embryonic Cell and Gene Therapy at the Oregon Health and Science University in Portland, Oregon. I'll ask a question. Has a human embryo, have we done what we did with Dolly to create her, Dolly the sheep? Has that been done with a human yet? Anyone know? He has done it. He has done it. He has done it, but they killed it within days. Dr. Mitalipov and staff in 2013 created multiple human embryos for research purposes in the laboratory. Although none of the embryos were allowed to develop for more than a few days, and there was never any intention of implanting them into a womb, the experiments are a milestone on what may prove to be an inevitable journey toward the birth of the first genetically modified humans. I mean, are we playing God here? Are we playing God? Kind of seems like it. Right? Now, on to the next subject. This is assisted reproductive technology. It's ART, as it's shortened and called, represents all treatments or procedures that involve surgically removing eggs from a woman's ovary and combining the eggs with sperm to help a woman become pregnant. Okay, and there are two categories of that. One is artificial insemination, which is not so bad, even from our church standpoint. It's serious in that a couple has tried, they're having very little success. But sperm is collected, sperm is introduced directly then into the woman's cervix. The egg is fertilized in the woman's fallopian tube, and pregnancy then proceeds in the usual way. Well, yeah, we're not having conjugal love to start things, but this doesn't seem to be as serious a consequence here. We're not killing anything along the way here, right? Now, on the contrary, in vitro fertilization, ovarian hyperstimulation using fertility drugs. So a woman, now this is a topic too that I have a lot of concern with, because I can understand people, a young couple is trying terribly to conceive and having no luck, no success. It could be going on for years, and you put yourself in a situation like that. But, you know, we do have to draw the line somewhere. So what happens here is that the woman's ovaries are hyperstimulated to produce more eggs, and they do that with fertility medication and drugs. Then they retrieve the eggs by direct needle puncture of the follicle. This is not easy to do. Technicians are trained, doctors are trained. This is not easy to do. There's always risk involved. And then collection of the most motile male sperm. There's a term called, I think it's washing the sperm. Washing is how they call it, where they actually separate the slow-moving sperm in favor of the fast-moving sperm. This seems to accelerate the opportunities for pregnancy to occur. And then a manual combination of egg and sperm in the laboratory dish. So they take out a petri dish, they put the results of the sperm, of the egg in that dish, and they wait for it, or they assist it in its combination, creating an embryo, right? And then they transfer the embryo back into the uterus. Husband and wife, or mother and father, where's their role in this? I mean, they're bystanders, basically. This is done outside of the body. This is done in the laboratory. So, what are some of the concerns? Of course, there's typically multiple pregnancies, twins, triplets, and certainly well beyond, are common. However, with a multiple pregnancy that results from IVF, often one or more of the embryos are then killed in a process called embryo reduction. I spoke to a woman who went through this, and how the doctor explained it to her, I thought was so horrifying. They put a spin on it that we take the viable ones, those that we know are going to make it, you know. They don't really talk the truth in some of these things. They don't tell people that they're actually going to kill these others. Most people will take out, or most of these, it's about 10 or 12 eggs if they can. It's whatever they can, but if they have enough, they'll take 10 or 12 eggs out. And then they'll implant anywhere from like 2 to 4, 2 to 5, something like that. And they'll wait and see which 2 or 3 are most viable. And those that are not, they will actually destroy them. And then it leaves 4 or 5 others that are still sitting in a petri dish. So we're going to talk about that too. The embryo is conceived but not transferred. All right, so again, these are living human beings. Conceived but not transferred are either destroyed or frozen to be transferred later if the parents want another child. If the parents do not want to transfer them for a new pregnancy, they are preserved cryogenically or frozen indefinitely. There's quite an interesting call behind that. The frozen embryos, I understand it costs about $350 to $1,000 per year for a family to utilize that service. But again, I'm going to point out a couple other things about that as well. But these are some more moral concerns about this. It replaces the conjugal act between husband and wife, sperm and egg collection without the marital act. That's exactly what's going on. Often requires the donation of reproductive cells from a donor. So if we can't get enough egg, or if we can't get enough sperm, then they reach to another source to bring it in, and then they'll implant afterward. Place the art of procreation in the hands of the doctor or laboratory technicians. Again, parents are mere bystanders. Sad. Now this is a shocking stat right here. This is in the United States alone. Over 600,000 cryopreserved in liquid nitrogen human embryos exist in the United States alone. Over 600,000. Where on earth well, we know where they are. What are we going to do with these? Even if you say, give them the research takes up about 3%, not even. I think it was 2.8%. Where are all these children going to go? What are we going to do with these? These are living creatures in frozen, suspended animation. They are not dead. They are living in suspended animation. Donum Vitae, tremendous reading if you're really into this. Cryopreservation constitutes an offense against the respect due human beings. This is serious stuff. Where are all these children? What are we going to do with this? And finally, euthanasia and assisted suicide. This topic here, since it's so close to our hearts, in New Jersey, we're going to have a big vote coming up in the very near future. I don't think anything has been signed up. They're saying by the end of the month, perhaps. We're in a blue state, getting bluer by the minute. Almost navy blue now. What is euthanasia? It implies the intentional termination of life by another at the request of a person who wishes death. Two types, passive and active. A lot of that just kind of crosses over. You can cross it, go on. Physician-assisted suicide. Voluntary termination of one's own life by the administration of a legal substance with the direct or indirect assistance of a physician. A physician then now will be able to write a prescription, hand it to you. You can get it filled today, tomorrow, next month, next 3 months from now. You can get it filled right away and just keep it on your counter until you're deciding when it's ready to be used. Right? And of course, this is our famous Dr. Death, Jack Kevorkian, pathologist, and that kind of makes me wonder how he got involved in this kind of business of killing people. Pathologists usually do post-mortem work and a lot of cell examination, especially in his the years that he was practicing. But he's one of our violators, let's say. Some conflicts with it. It violates the Hippocratic Oath. There's this particular phrase here: I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect. The AMA has been against it. It states that physician-assisted suicide is fundamentally incompatible with the physician's role as a healer. Would be difficult or impossible to control and would pose serious societal risk. Interesting with the AMA, they're starting to lose their backbone on this. They're trying to shift more towards the center line. They're not saying they agree, but there's a movement towards the middle. And this is really getting a lot of doctors upset. I hear it when I go to the hospitals, and I hear they're not happy with this. In California, it was a big factor. The AMA in California, or the California Medical Association, they tried to get this through in California for years. Now it's there now, but it didn't happen until the Medical Association of California shifted to the middle, and then the floodgates opened. All right. Further complications that can result: disabled people. They face the greatest pressure to submit to physician-assisted suicide. So a lot of these people who are already disabled are saying to themselves, I'm not like everyone else. And now you give them an option to take their own lives, or give them the impression that maybe they should be taking their own lives. We lack adequate depression screening and treatment. And that I hear a lot from the hospice program people. They see it firsthand. Depression is a big factor there that seems to be frequently overlooked. Cost factors. People with cancer have been offered life-ending drugs over cancer treatment. Oh my God, I mean, what's next? These are insurance companies. They're going to end up saying, we'll cover for the drug, but we're not going to cover the treatment. That's what we're going to hear. That's coming. We seem to overlook palliative care. Pain management is significant. Hospice, tremendous. Psychological treatment. These are all factors that I think if we put some real effort into it, we're going to see the less of a need for physician-assisted suicide. And then I finished off with the Congregation for the Doctrine of the Faith. They state firmly that nothing and no one can in any way permit the killing of an innocent human being, whether a fetus or an embryo, an infant or an adult, an old person or one suffering from an incurable disease, or a person who was dying, nor can any authority legitimately recommend or permit such an action. I think that says it all in a nutshell. Where's the dignity of life? This is truly a stressful time in our lives. And I think the only thing, this is our last slide, thank God, right? Beyond the U.S., I have been watching the United Nations a lot in the past year or two, and seeing what goes on there with their ideas of Planned Parenthood. They want to bring Planned Parenthood to the world. That's their thinking. We had an administration that was very much in favor of that. For the first year of the Trump administration, things didn't change much at all. But bang, he hit them right between the eyes. This has changed 180 degrees. The U.S. is behind a big overhaul there, and I'm so happy to see it. If you really want to look into it, there's an organization, the Center for Family and Human Rights. You can get on their mailing list. They go by C-FAM, CFAM. It's well worth it. They send out something called a Friday fax, I think it is, right? I think you have it, Father, don't you? We were talking about it. And they talk about things going on in other third world countries that are trying to pull themselves out of desperate economic times. And you got to say something about the missionaries in this world. They've made an impact. There's a lot of very, very devout people out there who believe that life is certainly worth living. And they are truly a model for all of us. But that's a great group, a small little group too. There's just a few people involved. But boy, they are impactful. I've found out, I've learned a lot from them. So the level of the UN, we got to be very careful there. Thank God the U.S. is standing up to it all. And that concludes it, everyone. I'm sorry that took so long. And if there's anything I can answer, yes, Jim.
I have one question. That's the figure, 600,000. Geographically, are they all in one place, or are they?
No, it's spread all over the country, Jim.
College universities?
Mostly, I don't know for sure. I guess it's in research centers and laboratories and places like that. But that's an incredible number. I know it's throughout. I know that's a United States number. I'm thinking I've heard something about 1.2 to 1.4 worldwide. So that's pretty significant. A million babies out there. Yes, Father.
I know, like the embryonic stem cell is very immoral. How do you get adult stem cells?
That's where through the afterbirth and the cord, I'm sorry, that's what I'm looking, thank you very much. Basically through the cord. And that's a big area where they utilize the adult stem cells. And they have been proven to be incredibly beneficial. Like I said, the current embryonic stem cell research has 0 success. Everything is in adult. I mean, they can't say one thing, but these researchers, they see potential there. And again, you know, what their motivation is, we have a lot to speculate. Yeah, Dave.
I know you touched on artificial insemination.
Right.
But it's not that bad, I guess, compared to the other methods.
IVF, yeah.
It is much worse. But the church is still against artificial insemination.
Yes. But I'm happy that there's no killing there. But
Still, the church looks at it as being intrinsically.
yeah, I mean, there's mechanical involvement there from outside sources to see that it all happens, right? So it's really taken, again, out of the hands of the couple, the husband and wife. Yeah. John?
I understand that there are quite a number of hospitals which permit abortions. And I also understand that there's a tremendous pressure on the doctors to do that, or if you are not doing that, you've got to look for another job. How much of that exists today?
I don't know if I agree with that, John, totally. I'm sure they're under pressure. The doctor wants to stand his ground, he can do it. You know, if you're in a hospital setting that's encouraging it, it's tough. It's tough, but, you know, you got to sleep with yourself at night, right? I don't know a lot of the obstetrics and gynecology guys, but those that I do, there's some that are pretty stand-up guys and gals, and they will, you know, they'll say what they believe and they'll follow through with it. But, you know, patients come in and ask them to do things too. So they got to set it straight as to what they're willing to do, what they believe they can do. And patients will walk out because they'll find someone else who will do what they want. You know, so you got to, I look at it this way, you got to be able to sleep with yourself at night too. So that's truly in their own hands as well as in, but the pressure is there, no question. The pressure is there in certain places, Yes, Joe.
Thank you.
Oh, Father?
I was going to say, a lot of you know, are from this area originally, and you're St. Francis babies. And you may wonder why did St. Francis give up its maternity unit. Dr. Alfred DeBoy, who was very pro-life, he's passed away since. He had a patient who was a medical social worker. Her husband was an attorney. They gave birth to a Down syndrome child. They sued DeBoy. They sued St. Francis Hospital for not informing them where they could get an abortion. Now, we're talking in the 80s. I mean, a lawyer and a medical social worker.
Yeah.
And the hospital lost, Dr. DeBoy lost actually a couple years later. He gave up his practice and only did GYN. So there's the whole financial thing.
Sure it
That's
is.
why the only Catholic hospital in this county, that's why they gave up.
Yeah.
On the other hand, we have the hospital out on Cherry Hill. And, you know, there's literature there. If you want to have the abortion there, they don't push it. The other thing is you really have to watch changes in administration. At one point, Susan Komen was blasted all over the GYN clinic at St. Francis. And the administrator and the local nurse supervisor had no clue this was Planned Parenthood. And I tiptoed very carefully and we went up through administration. I was told, Dr. Brennan, they give us a lot of money for our free clinic. So I dialed the chancery. Those signs came down the next day.
Good for you.
Yeah.
Good for you.
So you have to be your own advocate for your family. And then the other thing, the other end of life, there are hospice programs out there that come to the home. You better know who you have, because initially, you know, a lot of you know my mom had a stroke. She didn't have dementia, but she was very weak, and I needed hospice at one point. And I went through the hospital, and they sent a company from the Red Bank area, and they were like, the second day, well, you know, your mother's suffering. She's never going to get better. She's 95. You need to be kind to her. That was the last day they were in my house. I was like, if you need somebody in the area, Holy Redeemer Sisters have the Holy, they actually have bought Mercer County Friends, but it's the Sisters of the Holy Family who have Nazareth Hospital in Philadelphia. They have moved into Burlington County, Mercer County, and they bought up, you know, so if you have a loved one or you have somebody who's long-term ill, you know, somebody with MS or something, you have to do your homework because
You truly do.
out there.
Yeah. You truly do.
It's hard.
Yeah. Yeah. Father, you like to say something?
Yeah, I agree that we'll soon probably come to a point where we won't spend money for some type of treatment at the end of life, probably with a terminally ill patient, just because of the expense of it. And the surprise, actually, we haven't gotten to that point yet. What is preventing that? When so much of the percentage of healthcare is spent at the end of life, you wonder why there aren't more.
Yeah,
models
yeah.
that-
I guess in certain places they are advancing that a little bit further. I usually see that these things, they pick up momentum over time, and certain areas of the country will start pushing it, and before you know it, you know, these insurance companies are massive. They're all over the place. They're all over the country. And once one takes off, and then I'll tell you the other part too, we got to watch out what the federal government does with all that. If the Medicare and Medicaid starts pushing that too, then those insurance companies are going to follow suit, because they won't make a move unless Medicare and Medicaid do the same thing. So they are really indicators. So look at the federal government. If they're going to let these things go on in that manner, then the private insurances are right behind them. That is a big thing I've noticed in all my career here in medicine. It's strictly, you know, it's great what the federal government does, and everybody likes to work with Medicare for the most part. You know, you're pretty much guaranteed getting a paycheck out of them, but what you have to do for that, the private insurances will follow what the federal government does and says. So if they start leaning in that direction, we're going to see a big change.
Have we seen it in some of the Nordic states already? Whether it's Iceland or Norway or Switzerland?
Norway is a big proponent. Yeah, Norway, they
They've already had cases where
absolutely.
where people get towards the end of their life and
Sure.
suffer from an Alzheimer's or something.
Yeah, that's a.
The state can actually execute, but they say it's more of a mercy.
They'll give the option to a 12-year-old over there, to a 12-year-old, to ask for death. It's insane. It's truly insane. Iceland said that they got rid of the problem of Down syndrome. Yeah, well, they basically executed the people with Down syndrome.
France, I mean, France is, going back a couple of years ago, one of the ministers of France, there were statistics that came out that said, because now they test for Down syndrome in all babies in France.
Yeah.
And they basically eliminated 96% of all Down syndrome babies born. One of the ministers got up and said, well, we still have that 4% to go. I mean, it's frightening.
Oh my gosh, incredible, incredible. Well, thank you, folks. You look as tired as me.